I'd like to take a moment to talk about direct threat and a direct threat analysis and its role in the accommodation process and in determining if an accommodation is appropriate to the context once it's been determined it's reasonable for the student. It most often comes up in clinical settings, although there are other places where that analysis may come up, and direct threat analysis may also come up in a discussion of, is a student otherwise qualified for participating in a general environment rather than is an accommodation appropriate. But it would be the same analysis. And that analysis is based on, is the threat real? What is it? Is it imminent, as in likely to happen soon? What are the consequences or magnitude? Is it a serious threat? And can it be controlled by reasonable accommodation, by modifications to the environment, by the use of adaptive equipment or tools? In that process, you might take an example of a nursing student who uses a wheelchair. And we hear often, or I have heard often at least from nursing programs, well, that's problematic because the wheelchair collects germs and dirt from rolling in. It's controlled with your hands, and then you interact with the patient, and the risk of infection, the risk of disease transmission is a threat to the patient. So the analysis there would look at, how is that different from me walking in the door? Is this a context where there's a need to gown and put on paper booties and a little paper hat before going in the room, in which case we might discuss it's not very easy to gown a wheelchair and how do we compensate for that. If they were to point to, but you move the chair with your hands, unlike walking, and in doing so you pick up contamination from the ground, someone who really understands locomotion in a wheelchair would recognize that the rims that you use for propelling yourself in a manual chair are not the tires themselves, and so that's probably not a true risk. It's not an imminent and likely risk. But it could also be mitigated by the use of gloves, by the use of hand wash and sanitizing that's in the entrance to most patient rooms. There would be a number of ways to mitigate that risk. So that would be kind of the model of the analysis. It is an analysis of risk to others. When we talk about otherwise qualified, we sometimes are concerned with risk to self, but under the ADA amendments, direct threat analysis is really one about risk to others and impact on others, not self. So we don't want to be paternalistic or maternalistic, but we do want to protect the environment or make sure the essential elements of the program, and patient safety in a clinical setting would certainly be one of those. Final example in the other direction, so a dental student, say, who needed more time as an accommodation, slow manual processing, and would like a little additional time in working with a patient in the chair. The question would become, what are the risk factors with increased medication time or medication wearing off in pain and control becomes the issue for the direct threat analysis in that case. And there are some real limits to how much medication you can safely administer to a patient and extend it. So the question would then be one of quantity and volume, how much extra time was appropriate, how much extra medication were within reasonable guidelines.